In terms of Barnet, there are a number of organisations that make up the structure of primary care. Rafif and I are working with the Barnet Training Hub, and the role of the Training Hub is basically to improve patient experience and patient care. That's sort of the at the centre of all the work we do. And we try and achieve this by improving educational training for clinicians and also in social care. All of our work is community focused. And another very important aspect of our work is about promoting the well-being of the workforce. You're all part of our workforce, and we recognize that having a happy, well-supported, well-trained workforce is the best way to deliver good patient care. And that's partly what this new induction program is about, is trying to offer better support to all of you from the beginning of your roles. The CCG is the Clinical Commissioning Group, and they are responsible for the funding of all of the community and hospital services. The CCG, is the sort of, well, the commissioner, and you should see the trusts and the hospitals and all of the local services as the providers all bidding for certain services. The CCG used to be Barnet CCG, but in April last year, Barnet merged with Camden, Islington, Enfield, and Haringey, and we are now NCL CCG. But there is still, separation of work. So Barnet Training Hub is part of NCL Training Hub, but they do still work independently as well as part of one umbrella group. And then the Federation is a group of GP practices. In some areas, you'll just have a small number of practices forming a federation, but in Barnet, all of the practices form Barnet Federated GPs. The purpose of grouping together is to pool resources. So certain services like extended hours, extended access appointments are run by the federation, so that each practice doesn't have to provide individual, out of hours appointments in the surgery. They can pool it all together, so it's more efficient that way. And there are other services run by the federation, such as the pharmacist-led anticoagulation service, the diabetes quality improvement service. So the federation runs a number of services that it's important to be aware of, and they work closely with the training hub. And then the PCN, so this is another way of grouping smaller numbers of practices, again with the purpose of pooling resources, particularly when it comes to roles such as yourselves, which fall under the term of ARRS, or additional roles reimbursement scheme. So it allows a group of practices to, for example, employ one person to work between multiple practices. And again, that's just about, it wouldn't be practical for a very small practice to have a full-time PCN pharmacist or a full-time care coordinator. So it's about sharing between different practices. And as you can see, all the PCNs have got different population sizes, different population needs. I mean, for example, PCN 3 has got a lot of care homes. So the other advantage of dividing into PCNs is that you can tailor what services you provide according to your sort of micro population needs. And I mentioned about the CCG is the commissioner, and then the hospitals and the community services are the providers. You've got the community hospitals like Edgware, Finch Memorial, Chase Farm. They have the urgent care centres, the walk-in centres. They provide phlebotomy services, physiotherapy. Then you've got your general hospitals, your secondary care with A&E departments that everyone knows pretty well in the area. You've got specialist hospitals like the National Orthopaedic Hospital in Stanmore, Moorfields, Great Ormond Street, and you've got your mental health trust as well. And all of these different providers are essentially commissioned and funded by the CCG. Moving on to your induction at your practice. So it's really important that you do all have a local practice induction. This, Barnet Training Hub induction is about giving you a general overview of Barnet, the makeup of it, and your role. But local induction is really important. So this isn't a substitute for that. So in terms of what you should expect to know by the end of your local induction is to make sure you've been set up with smart card access, make sure you have all your passwords for EMIS and DocMan, make sure that you've got an NHS mail account set up, and it's really important that the practice has added you to their mailing list. Learn who everyone is in your practice, learn what their roles are, and don't be afraid to ask for help, because everyone's there to work as a team. And so if you get to know everyone early on, it will make that a lot easier. Of course, make sure that you know how to book annual leave, how much notice you need to provide. Really important to find out what the local protocol in your practice is for reporting if you're sick, so that you don't have any last minute panic if you can't come in that day and you've got patients expecting a call from you. Make sure you know who to speak to so that they can let your patients know. Hopefully you'll never need it, but it is important for all practice staff to know where the emergency equipment is. And then hopefully you've all received a copy of the induction pack. Now, within that is admittedly a very long checklist, but it would be helpful for you, I'm sure, to just refer to that before your local induction and afterwards to make sure that all of the most important things have been done. The checklist is very long, so there may be some things on there that aren't relevant to you as care coordinators, but it'd just be a helpful guide. And also make sure you're up to date with your practice, with your mandatory training, whether that's through Bluestream or eLearning for Health. Those are usually the two main routes to do your mandatory training. There are a wide variety of roles in general practice, and the roles are expanding. You know, for example, care coordinators are new to primary care, and there are a lot of other new roles. As much as you can early on when you're starting your new job, try and understand all the roles, so that you can, you know, if you need help with a particular issue, you can go to the appropriate person. I think it'd be really helpful if your practice allows and if time allows for you to try and shadow a few different members of practice staff, because that's really the best way to get to know what their role is. Doesn't have to be for long. I think it really helps you to understand how the practice is run, if you can do that. The role of care coordinators is to work closely with GPs and other primary care professionals within the network. That's the PCN. And your role, along with health and wellbeing coaches and social prescribers, is to make up personalized care, which is one of the big sort of targets of the NHS Sustainability and Transformation Programme. The way you'll really help practices is to identify the high intensity users of the practice, and to make contact with them and help them, because there are small subsets of patients who take up a lot of GP practice time. Whenever you're writing notes, whenever you're putting information into EMIS, make sure that you know what codes to use and how to input codes, because it makes it possible for workload to be tracked and for audits to be done, and that will help to work out how effective the role of the care coordinator is in improving primary care. When you're working a session, when you've got a list of patients to call, that you know who you could turn to for advice if you're stuck, if you're not sure what to do, or you just want to discuss a complicated case. I would always recommend establishing at the start of your day or at the start of your week, or however they're going to divide it up, because it may be that there'll be different people for you to turn to each day. You just make sure you know who it is and discuss with them before you start about how you want or how they want that sort of supervision to take place. Do they want you to pop in and discuss a case as you go along? Do they want you to phone them, send screen messages, or to just keep a note of all of the questions you have or the cases you want to discuss and review them all together at the end of the session. There's no right or wrong answer. It's just about knowing what would work for both of you. And most importantly of all, don't forget that if you are new to the role, that everyone understands that, and there is a settling in period, and don't be afraid to ask questions, and no one's going to think any less of you. The time to ask questions is when you first start, so make the most of that settling in period. I just wanted to mention quickly about the CCG, the NCL CCG website. This link is also in your induction packs. It is a useful resource. Find out when your practice meetings are and ask if you can join. In particular, you know, your role is new, and a lot of staff, including GPs, won't really understand how it fits in. So, you know, be proactive. Ask if you can present at one of your practice meetings, you know, about your new role and how you can help the GPs. Emphasize in particular what I said before about, you know, that you can help with those high service users, the ones who call, you know, every day, and that you could really make a difference there. And then also think about, you know, are there any projects, any audits you can do, or, you know, anything that you can think of to help develop the role of the care coordinator. If you can add that to your work as well, you'll really feel like you're making a difference in developing the role. I would recommend that if you haven't already got one, to set up a care coordinator WhatsApp group for all of you to, you know, send quick messages if you have a question, because pooling your knowledge, pooling your resources is a really helpful way to feel supported early on, and then similarly ask to join your practice or your PCN WhatsApp groups and use them in the same way. Agnes at the CCG is very, very good, and she'd be very happy if you contact her and ask her for EMIS training. She can do half an hour. She has offered, you know, 90 minutes of training. So however much you want, just get in touch with her. So I just wanted to tell you about the text messaging service, AccuRx. I'm just on a test patient here now. If you look this green icon at the top, so this bar, once it's installed on your computer at work, which it should be, will allow you to send messages to your patients. So you just click on the icon top left here. That will open up the text messaging window. Just make sure that the mobile number is correct according to what's on your booked list. And then you can just type in here about, you know, please send a photo, and then make sure you tick this box here at the bottom, allow patient to respond once. You can use it for whatever communication you want. You know, there are no limits. Just make sure that the patient hasn't, you know, withdrawn consent to receive messages here at the top. When you send and save, it will automatically save that text message into their record, as you can see here. So, you know, that saves you having to type things up. It just documents the communication straight away.
Okay, here we go. So I guess the most important question to start off with is, what is a care coordinator? So as some of you mentioned in your introductions, you know, it sounds like a very exciting role. It's very new, but it's not very clear cut yet as to what exactly it entails. So if that's how you've been feeling, you're not alone. And as I say, it's part of my role is to sort of bring ideas together and formulate this role into reaching the potential that we want it to be. So, you know, at the beginning, some of you mentioned you've been working at the COVID hubs. We've been needing a lot of manpower there. And I think all of the PCNs are still deciding what it is they want you to be involved with. It will be varied across PCNs because different PCNs and practices will have different objectives that they will want you to achieve. But there are some kind of commonalities that the NHS who set up the role will want practices and PCNs to achieve. So we'll just touch on that this morning. So just put this quote up because I think it's quite a nice quote that encompasses what's going on in the NHS at the moment. So as you can see, as medicine advances health needs change and society develops, the NHS has to continually move forward so that in 10 years' time we have a service that is fit for the future. Obviously, this year with the pandemic, that's put in lots of new obstacles as well. Probably a lot of the things we were already struggling with, and they've just been highlighted and magnified. So the NHS does have a long-term plan as to what they want to happen in the next 10 years. And that's where your role actually fits in. So within this long-term plan, there is a huge emphasis on personalised care. So personalised care is a major part of the plan in which the NHS wants in 5 years for personalised care to be a huge part of the way we provide primary care in the community. So primary care means giving people choice and control over the way their care is planned, and to deliver their care with an emphasis on what matters to the patient. So, historically speaking, I think that there's been an idea where the healthcare professional knows what's best for the patient, and the patient will come to the GP or anyone else in the healthcare service to kind of guide them as to what they should do with their care. And the idea is to move away from that model and actually move in a more modern model where the patient tells us what they need and we try to achieve that and help them achieve that. So personal care, as I say, represents a new relationship between people and professionals, in which the healthcare system helps them provide a positive shift of power, where the patient has power in making decisions and ensuring that their voice is heard. So a little bit more about personalised care and why the NHS thinks this is really important. So it's been proven to improve people's health and well-being, and as you probably know, well-being comes hand in hand with health. So if you want someone's health to be better, they need to have a holistic. We need to have a holistic view of their well-being, making sure their their social aspects are looked into, their mental welfare is looked into, and that will have an impact on their physical health. It also is a way of joining up the care that's present in local communities at the moment. So we have great primary care services, but we do suffer from issues where we don't always have joined up thinking, where a particular service is doing one thing and another one's doing something else, and we're not really speaking efficiently between us to achieve the care that the patient needs, and patients find that very frustrating. We find that very frustrating. So the idea of personalised care is that a patient's care is not sort of compartmentalised, but actually brought together under one umbrella so that it works more smoothly. Another idea of personalised care is to reduce the pressure on the NHS service, and help the health and care service be more efficient. Sort of links back to the previous point, where if you're working more efficient, the pressure is less, and the services are less strained. So thinking about prevention, if we're preventing sort of crisis events, then we're reducing A&E presentations, we're reducing sort of emergency presentations with the GP, and so we are offering hopefully a better service where we're preventing worst case scenarios. It also helps with people, so particularly personalised care will help people with multiple physical and mental health conditions. As Will mentioned in one of his slides, it's people with numerous contacts with their healthcare service. They are the ones that are most in need of this sort of personalised care strategy, and for roles such as care coordinators to bring their care together, because they do take a lot of resources, and the nature of their conditions means they need a lot more help. So those are the sort of people that personalised care is looking into. And so personalised care recognises that for many people, their needs change depending on on circumstances that are beyond purely their medical issues. So, social issues is a huge factor. We know that people from lower socioeconomic backgrounds have higher health needs, and one sort of plays into the other. So the idea is to connect care and support services together, bringing services in the community together to be able to support them. Personalised care also has a positive impact on health inequalities, taking into account the different backgrounds and preferences, with people from lower socioeconomic groups also benefiting most from personalised care. So again, similar to the above point, as I said, COVID has shown us that health inequalities do exist, and they have a huge impact on your health. And so this is a timely sort of strategy to try and reduce the health inequalities that we know do exist. So you might be wondering, how does your role as care coordinators fit in with all of this? So actually, care coordinators, social prescribers, health and wellbeing coaches are three roles that have been introduced with one of the sole purposes being to bring out personalised care and to roll out personalised care in primary care. So they're termed additional roles, and they've been introduced over the last 2 or 3 years. So social prescribers have been the first sort of role that has been pushed, and so most of the PCNs will now have social prescribers that are working quite actively, and we've already noticed huge impacts on people's health due to the work that the social prescribers are doing. At the moment, we are rolling out the role of the care coordinators, and the thought is it's a sort of a triad of roles will together bring about this new personalisation of care that the NHS is trying to get us to achieve. So this is a nice diagram to sort of keep in your mind as to sort of a bird's eye view of how the service will work between the three roles. So as you can see, the idea is that people can refer either through the care coordinator or the social care or the social prescriber. So when we talk about referral, those referrals can come from different sources. So it'll either be a GP referring, can be reception staff, it can be anyone basically in the primary care setting, in the practices, and together they communicate between them, the three roles, to bring about the sort of joined up care that we'd like people to have. So this slide is similar to the one before, but a little bit more wordy, sort of puts in there the sort of roles specifically that the sort of aims that each role is hoped to achieve, and also these sort of circles will show you where these roles will probably overlap, and so there'll be a lot of joined up working between the three roles. Now, we don't have health and wellbeing coaches in Barnet from what I know at the moment. This will probably come into play in about a year or two once we've got the care coordinators set up. So we won't put a lot of emphasis on that. Just briefly, the idea for them is to provide actually training for patients as to how they can look after themselves in certain goals. So some of you might have joined the health coaching course that was on a few months ago. The health coaching ideas also open for everyone to try and encompass in the way they consult with patients now, as part of the idea of personalised care, where you give the power to the patient to make positive changes in their life and their health. But this role will be specific for that. So care coordinators, we've got on here that they provide coordination, navigation and support across health and care services. And they can speak to the social prescribers who will build personal resilience through connecting and building communities. This image just sort of gives you an idea of the other roles that are around in PCNs that some PCNs may have. So the idea is to sort of make the primary care a network between different professionals who can work together to achieve the goals that the patients need. So whereas sort of historically speaking, we really think about the GP and the nurse and the practice. Now we've got a variety of different roles that are contributing. So we've got pharmacists, some people have mental health practitioners, some people have dietitians. So your role, so as care coordinators, is one of these roles in the network to try and achieve good care for patients. So to focus on the care coordinator role a little bit more, what I'm going to do is they're a bit wordy, these squares. So care coordinators play an important part within a PCN to proactively identify and work with people, including the frail, elderly, and those with long-term conditions, to provide coordination and navigation of care and support across health and care services. So I've highlighted the buzzwords that I think are quite important. So proactively identify people that need extra help. So as we mentioned before, so it's those patients that are seeking help a lot, that don't have many advocates, that don't have carers who can sort of navigate the system. So as you can imagine, you probably come across, frail patients who've got multiple appointments that they struggle to keep up with, struggle to get to in terms of organising transportation, just those sorts of patients who need someone to sort of guide them and hold their hand, that historically we've not been able to have the capacity to arrange efficiently, at least. This square over here. So the idea is that they will work closely with GPs and practice teams to manage caseload of patients, acting as a central point of contact to ensure appropriate support is made available to them and their carers, supporting them to understand and manage their condition, ensuring their changing needs are addressed. So eventually, the hope is, as a care coordinator, you would have a number of patients that you see on a regular basis, that you are helping them navigate the system, helping them understand their long-term condition, helping their carers to support them. So whereas initially that might be a little bit difficult because, as we say, we're still trying to identify which groups need, someone like yourself to help them. That might start off in some practices earlier, where the practice may give you a group of patients who they believe are struggling, that are vulnerable, that are high risk, and they will ask you to sort of see them on a regular basis or speak to them on a regular basis. So the idea in your head should be, how can I help this patient understand and get control of their condition? Okay. So this is hopefully achieved by bringing together all the information about a person's identified care and support needs and exploring options to meet these within a single personalised care and support plan based on what matters to the patient. So I think the luxury of a role such as a care coordinator is hopefully you'll have more time to spend with the patient to bring together the information that the patient finds important about themselves. So, in an ideal world, this is what a GP is trying to do. We are sort of trained to have a holistic view of the patient and try and bring different aspects of their life together. Realistically, we struggle to do that. We have very limited time in our appointments. You may be able to solve one problem in a 10-minute appointment, but it's difficult to, gather people's different ideas together. And so as you probably know, we get in a problem with patients who do have lots of problems where they think they're not being listened to. So while we all have the intention of bringing their information together, we don't have the capacity. So that's where this role play comes in. The hope is your role will give that capacity so that someone is bringing together all the different information, understanding what matters to the patient, and then making a plan, which then the GP or the nurse or other healthcare professionals can look at and understand before sort of dealing with them about, during a 10-minute consultation. And then here we've got care coordinators could potentially provide time, capacity and expertise to support people in preparing for follow-up clinical conversations they have with primary care professionals. So not only is the care coordinator identifying what's important to the patient, sometimes there are kind of very important conversations that we're having to have with patients over a 10-minute appointment, and that might not give the patient enough time to form a decision or gain the information that they need to make an informed decision. So again, the role of the care coordinator is to support them in making those decisions before a follow-up appointment is made, where the care professional can speak to the patient again about things. So this is just sort of zooming in on some of the aspects that were in one of the images before. So again, some of the ideas behind the role is supporting people to live independently and increase their levels of well-being. So as you can probably imagine, if you are a patient with long-term problems, with chronic health problems, unless you understand what those problems are, how the condition is going to impact your life, it's probably difficult for you to be able to take some control. So the idea is that the patients with long-term are not as dependent on their healthcare providers as historically they may have been, helping them to live a more independent life where they have a higher level of well-being. And then we've got prevent deterioration and reduce unnecessary service utilization. So I touched on this before. So if you, proactively speak to these patients who have multiple conditions, who have multiple medication and multiple issues, social care issues, if we are looking at those proactively in primary care, hopefully we can prevent them from escalating and reaching a crisis point where they're ending up in A&E in the middle of the night. So we all have come across cases where, an elderly patient will have a fall at home, there's no support that's available that can come in and look after them. So if in primary care we're able to proactively identify those patients who are at risk of falls, to give them some support, equipment, carers, that sort of thing, we can hopefully prevent them ending up in the worst case scenario in the hospital where the care will not be suitable for them. So again, the idea of the personalized care plans is to identify those risks and identify the needs that patients have to produce their need for ending up in hospital or even needing an emergency doctor unless it's suitable. And over here we've got provide coordination and navigation of care and support across health and care services. So we hear from patients again and again that people aren't speaking to each other and that they're not able to access other services easily. I think historically the GP is the first port of call, and so they're always coming to the GP to try and sort out other issues. But realistically, we don't even have the ways of reaching hospitals or reaching other services. So hopefully one of the aspects of the care coordinator role is for the care coordinator to be a central aspect within the GP surgery or within the PCN, who has some knowledge of the different services, has links with different services, so they're able to guide the patient and help them to navigate the system. So, for example, if they've got multiple appointments that are clashing, if they are the sort of patient that doesn't have an advocate who will find it difficult to access hospital telephones, we've all been on the phone to hospitals waiting waiting for minutes on end. If it's a patient who needs it, the care coordinator may be able to liaise with hospital staff, to liaise with transport, to arrange appointments for the patient. So you may be thinking, how will the care coordinator be able to achieve all these wonderful goals? So as we say, so one of the most important aspects is to proactively identify the patients who need this. So again, classically thinking about the patients that do come forward, who do utilise primary care and GP services most, it is patients with multiple conditions. However, they tend to be the patients that don't have the best care outcomes, and it may be for different reasons. It may be for reasons that their well-being is not up to scratch, and so they've lost the motivation to care for themselves, and so are not able to take control of their care. So the idea for the care coordinator is really to support people in actively being involved in their care. So, we want to pass the baton on to the patient. We want the patient to have control and to be able to manage their conditions themselves. So your role is to support them, to lead them to be able to do that. So not necessarily doing it all for them, but actually training up the patients to let them know that they have control, they have responsibility also, but this is what we can do to help. So part of that is to understand and manage their condition, ensuring that challenges and needs are addressed. So, there are reasons why people will struggle to, arrange follow-up appointments or attend their appointments. Historically, we've always been a little bit telling off, why didn't you attend this appointment? Why didn't you follow up? But really someone having the time to understand the reasons behind that and trying to find solutions to the problems. And as I said earlier, so preparing for follow-up conversations with primary care professionals. So this is sort of important. Sometimes as a GP, you'll spend a lot of time, or try and spend a lot of time with a patient, and then give them an opportunity during follow-up to discuss those issues again. But actually during the follow-up, you find that they haven't really made any movement, and the idea is so, those contacts with the GPs, with the consultants aren't lost, and actually there's some work done in between, so that we do go forward in terms of their care. And lastly, it's, the ideal is to develop these personalised care and support plans. Now, we hear a lot about these personalised care and support plans. We haven't really got a template or an exact formula as to what that will look like, and we will, work together with you to develop these plans across Barnet, so it can be more specific to the local needs. But the image I've sort of collected in my mind, having looked around things, is the idea of these plans is for them to be there on the system for those more complex patients, so that a professional who's going to come in and deal with them for the first time can have a quick look at this plan and sort of get an idea of what this patient's life looks like, what matters to this patient, what challenges they're having at the moment, and how we can help empower them to look after their health a little bit better. And then, so one of the ways in which care coordinators are going to achieve these things is proactively identify these patients, and also then actually help support them by providing the coordination and access to the appropriate services that they need. So this can vary, depending on the patient, depending on what kind of care they will need. You may find yourself in a role where you're making lots of phone calls for them, you're arranging appointments, you're arranging things for the patient, or you may be collecting ideas about services that are available in the community that you can then take forward to the patient, so they can go, take charge and access those services themselves. So coordination, it's in the title, and it's thinking about sort of help linking the different services that are out there. There are lots of services, and I think most of them are underutilized already. For example, the voluntary care service, we're trying to tap into that more through the social prescribers. So that may be something the care coordinators will overlap and do as well, but also sort of the services within the communities to have an idea, for the care coordinator to have an idea about these services, and so bring them forward to the practices and the patients directly. So I just put on this slide a few of the adjectives that come to mind when I'm thinking about the role of the care coordinator. So I put in the middle node. So, I heard someone sort of mention that when we were talking about care coordinators. So the idea is for the care coordinator within the practice or the PCN to be the central node that people within the practice, so the professionals, your colleagues, can come to you and ask you, do you know what services available for this sort of thing? Do you know much about this patient? So that's why you're the node. So you're the central person that different people can have access to, and also for the patients to have a central contact within the GP practice or the PCN. Those. Eventually, you're probably someone who's well known by these complex patients that people can ask for by name, to try and guide them. So classically, as we say, patients will sort of think to book an appointment with a GP or a nurse to discuss these issues. If it's not a medical issue purely, they may want to speak to you instead. And the idea is for your role to be some of these things that I've listed. So you're a patient advocate, you're empowering the patients to take charge of their care, you're supporting them in managing their conditions, you're helping navigate them through the system, you're enabling them to take to be able to take control of their care, motivating them, and this is all very new to patients. Most patients, obviously, let's not generalize, but most patients are looking at us, expecting us to solve all these problems. So it's a stepwise approach to actually introduce the idea to patients that actually you have the best resources within yourself to take control, but we are here to support you and motivate you and help you navigate the system. Guide, you're someone to guide them through the different issues that they may have, and coordinate their care. So between colleagues, between different services, that's the hope. So this is something that a GP recently said. So care coordinator is my favorite new member of staff. So as a role, this, GPs are desperate for a care coordinator to come in. So, we would love to be the people that call, go around making calls, trying to coordinate a patient's care, especially now during the pandemic. We're getting so many calls about, I've not heard about my hospital appointment, I've not heard from this, I've not heard from that. And we don't have the time, we don't have the capacity to be making those calls. And we do recognize, while some people, it's appropriate to let the patient know that it's their responsibility to make those calls. We know that some people are vulnerable and are not able to, and we don't want the health inequalities to get worse. We don't want those that are most vulnerable to be the ones that are at the bottom of the list because they weren't able to chase their appointments, for example. So, as a GP, this would be a great addition to the practice, and the GP who said this, she's got a care coordinator in place at the moment, and she's sending her tasks and asking them to liaise with the patients to sort these things out. So everyone's very excited about this role. So taking a step back and thinking about how we're going to achieve this within Barnet. So as I say, I'm one of the people who hopefully will help train and support you all in being able to reach the potential of this role. So some of the things I've thought about that could help you do this. So peer support. Everyone talks about how important it is to be able to speak to people who are doing sort of similar roles, especially when it's a new role, to be able to talk within yourselves as to sharing patient stories, sharing struggles, sharing different training opportunities that are available. It's been proving time and again that within training, especially in the medical field, peer support is really important, especially as you know, in the medical field, we do come across patients with difficulties that will invoke emotions within us, that will invoke you know, different challenges, and it's nice to have someone who understands what you're going through, that has been in similar situations in the past, and just to have a platform to discuss these sorts of things. So that's one of the things we'll be hoping to provide or bring together. The next thing is guidance and supervision. So we'll mention this in the induction slide. So supervision is very important within the GP practice or PCNs, especially when you're first starting out, because especially if you're quite new to the medical profession or the community, there are a lot of things that you will not have ever come across before. It is quite a niche job that we all are involved in. So having a named supervisor within either your GP practice or the PCN would be ideal. Obviously, this is going to vary across the patch, where you know, even within your GP practices and the PCNs, not everyone is yet quite clear as to what the job is. So, you know, I'm discussing this with you today. I'll be hoping to speak to practices across the patch to introduce this role to them as well. And the hope is to encourage them to give you a GP, you know, on the day, or just generally, that you can go to with your questions, go to with your cases, and discuss difficulties with them. Zooming out from that, I'm available as someone that you can come forward to with any cases, any difficulties that you're having. You know, I'm hoping that we're going to have some training sessions every 2 weeks initially, or maybe once a month going forward, and also provide you with some one-to-one time where you can bring forward other challenges. And guidance generally. So there is a lot of training that's out there already. So it's difficult to know that it's available. So I'll be hoping to sort of disseminate that between you, so that you know where it is to access, you know, where the training is, so you can access it and get involved and get yourself up to scratch. We will hopefully be doing some training sessions between us, and you know, I'm taking it back to foundations, as we kind of discovered in the introduction. Some of you have been working in the NHS for years, have been nurses in the past, so you're probably very experienced. I do believe that everyone benefits from a refresher every once in a while. I think sometimes you're slightly disadvantaged when you are experienced, because people sort of assume that you know all these things, but sometimes it's useful to sort of refresh your learning. So going back to the foundations that we all need in primary care, so communication skills, so important. You know, I've been a doctor for about 10 years now, and although we had this training in medical school, I'm always thinking about how I can develop my communication skills. And then other sort of foundations would be things like consent. So this is a huge, important part in patient care. We need to, you know, ensure that patients consent to different aspects of their care. So touching on those issues, information governance is important. Something that, you know, again, if you've never worked in the medical field, you may not have come across. So that will be something we need to think about. Safeguarding, again, very important. Adult safeguarding, children safeguarding, frail patients. It's, you know, something that you may have done some training on already through Bluestream, but it's always useful to talk about these issues to make sure we're all up to scratch. Capacity, again, very important, especially with patients who are vulnerable, who are frail, mental health problems. So discussing the issues that are around the issue of capacity. Record keeping, you know, it may sound simple and we may not need a whole session on it, but something important to touch on, especially as you are the coordinator. You know, people will be reading your notes and really utilizing the notes. So it's a good idea to have a good basis as to how you keep accurate and precise records. And then that brings the other aspects of long-term conditions. So we've talked about these patients with long-term conditions needing the most support, and will be the patients who you are likely to be most involved with. So it's probably a good idea for you to have an understanding of these long-term conditions. So we wouldn't be expecting you to obviously provide clinical support for the patients, but having an understanding of the condition helps you to understand what they might be going through and helping them understand and manage their condition. So we'll be touching on some of the most common long-term conditions and discussing different aspects. So this is not a kind of complete list of long-term conditions, but some of the most common ones. And then, you know, how are you going to have access to this support and training? So we've talked about the WhatsApp groups. So as Will says, we've all, you know, got lots of groups on our phones. You know, as probably someone who does use WhatsApp a lot, it is an easy way to access people. So if you are interested in being involved in the WhatsApp group, please do leave your number in the chat, and I will be setting one up. Hopefully, you know, it won't be too much jargon in there. It's a way where we can communicate, let you know where there's training events. You can talk between each other and send any information that you think would be useful to the rest of the group, and it helps that kind of peer support that we spoke about. We can obviously also do email threads and discuss cases there. So we'll see what the majority will prefer. Another part of setting you up and training the role is liaising with the MDT team. So social prescribers, as you saw from the image, that the triad of the roles, you will be expected to work with the social prescribers quite a lot. Now, the social prescribers, as I said, in Barnet have been up and running for a while, and they do have some concerns about, you know, where their role ends and your role starts, and we don't want there to be any friction between the two roles, but actually they will be working together to achieve different similar things. So across the patch there might be some variation as to what the social prescribers will be happy to do and what they would like the care coordinators to do, and likewise. So we'll actually be thinking about doing some joint sessions with them to understand what their role is, and to access the support that they have. So, you know, they've already built up relationships with the voluntary sectors. So Age UK just comes to I think they are supported by Age UK, so they've got good access with that. So we'll be utilising their training and their knowledge for you guys, so that you can access that information as well. There's obviously community nurses in the primary care, who within your area is probably very important to know who that is, maybe have some access to them, so that they can have someone to feed back to the practice about frail patients. So just, you know, if you think about, okay, district nurses, for example, who go and see complex patients all the time, we unfortunately don't have much opportunity to speak to them. There are some emails that fly back and forth, but if they had someone at the practice they could meet with on a regular basis, so that you will have an understanding of what the district nurses are doing with those patients, and then you could feed it back to the GPs and the rest of the practice during a clinical meeting, for example. So it'll be important to nurture those relationships. And also thinking about relationships within the practice with the reception staff. So reception staff will sometimes find it difficult to communicate with these patients with complex needs, or who you know, will calling all the time to make lots of appointments, and they're trying to manage them. So it's useful for them to have someone else to sort of direct the patient to, who may know them quite well, rather than utilising another GP appointment that is going to waste. Next, I've put on their health coaching and motivational well interviewing. So I mentioned this about the health and well-being coaches. So that's sort of what they're thinking for that role, but actually they want us all to start thinking about sort of putting into our ways of consulting with the patients, aspects of motivational interviewing. So I think some of you guys were involved in the, what was it called, health coaching course that was on a few months ago. It's a different way of consulting with the patient. So it's letting the patient guide you as to what they want to achieve, or you're guiding them in achieving certain goals. So at some point, you know, I'll try to give you information about where there's health coaching training happening, and you can get yourself involved in that. So that can be a big part of the way you consult with the patients. And then we come again to personal care plans. So that will come down the line. No rush to be thinking about that straight away. Once you've established the caseload of patients that you're dealing with, we can then think about putting it in a formula that different health professionals can have access to, where what's important to the patient is there, how we can work around the challenges, and what support is needed for them. I put at the bottom there, this is all a work in progress. So there's some ideas about what the role is going to entail, but we definitely want to hear from you about what you think is needed, what challenges there are, and how we can bring this role up to its potential. So again, this is an important part of this forum. So myself, I can communicate with the training hubs, I can communicate with the PCNs to let them know what difficulties you're having, what ideas you're having. It's always better, lots of minds thinking and bringing ideas together from the grassroots. So you are the people who are going to have most access to these complex patients. So we'll be guided by you as to what you think they need and what you think your role can be helped with, and what training you need. Just to touch on that, so I will hopefully be sending out a questionnaire around to all of you about what sort of training you think you need. So Will touched on EMIS training, for example. We didn't include that in the induction because we're aware a lot of you have been working with EMIS for a long time. But if we put that on a questionnaire, if you let us know if you do want some, we can have some sessions where you can have access to some EMIS training. And other aspects that will be in the questionnaire. It won't be too long, but will be really useful to understand what your needs are at the moment, and that will always change. And this role will change as it goes along. So have an open mind. Be flexible, take initiative, let us know what you're thinking, and hopefully we can work together to actually, get this role to reach the potential.